Okay, we move on with Daniele Angelella and Emanuele Sarcinella. Daniele is head of sports medicine at the Swiss Olympic Medical Center in Lucerne, team doctor of Swiss Athletics and chief medical officer of Swiss Rowing. Emanuele Sarcinella is head of Physiotherapy in Montebello in Bellinzona in the beautiful Ticino. A clinical setting who tries to implement advanced techniques in physiotherapy in the rehabilitation of athletes. He's president of the Swiss Association of Invasive Physiotherapy and a teacher in percutaneous electrolysis and neuromodulation. I had the chance to visit a workshop a couple of months ago, and I was really fascinated by his accuracy, how to place the needle right to the muscular lesion or right to the neurovascularization of a tendinopathy, and really close to the nerve for neuromodulation. The floor is yours.
Thank you, Patrick, for the presentation. I start from the medical part. I'm Daniele Angelella, and I learned about this technique when I started to work at the Cantonal Center of Sports Medicine in Tenero about 3 years ago. I had more and more patients that were telling me, well, I did this EPM, this musculoskeletal percutaneous electrolysis, and well, as any of us should be, I was curious about it, and so I decided to explore it, and I came pretty fast to the name of Emanuele, so I took contact with him, and through the story of 3 patients that I would like now to tell you, I discovered this technique that in my opinion is quite an interesting one. Let's start with the first one. It's an athletic sprinter. As Patrick said, I work with Swiss Athletics, so that's quite a common story for me. 27-year-old competitive sprinter, persistent muscle tightness since a hamstring injury 2 years ago. After heavy sprinting or high load, always this pain. On the ultrasound, you see pretty well there is a scar tissue, not a fresh scar, but an old scar. He did once the EPM, and this pain went away. So this sensation of tightness he had for 2 years simply went away. He surely did as well after the treatment some active rehab, but it was, for me, I put on red for what for me was quite impressive. It was 1 session, and afterwards pain-free. The second patient was a volleyball player complaining about patellar tendon symptoms. He already saw many doctors and physio, did active program, did PRP, and finally the surgeon proposed surgery, but the patient wasn't ready to do that because he was planning retirement in 2 years. He did a cycle of EPM, and the pain reduced pretty much, and he was still playing, and now he just retired. So, well, I think that was a surgery that was avoided, and now without doing sport is actually pain-free. And the last one, it's for me quite emblematic, probably the most, where I was most, I would say the first time also shocked. Hip pain in the context of femoroacetabular impingement for 2 years. The surgery is scheduled, and during season did once the EPM treatment of the anterior capsule of the joint, and by treatment of the capsule, the pain went away. And it was, I have also many patients that do during the season, like injection in the joint. The effect is stronger.
Thank you for the invitation. I belong to Invasive Physiotherapy, the percutaneous ultrasound electrolysis, on the percutaneous ultrasound neuromodulation. We can find the cycles in bibliography USGAT on PNI. In neuromechanical concept, we can find problem in the structure, and we can modify the structure through the EPM. The EPM modified the structure, and we also work or influence the dysfunction through the neuromodulation. And what is the percutaneous electrolysis? Percutaneous electrolysis is a technique in which a physiotherapist inserts an acupuncture needle in the soft tissue, tendons, muscle, bursa, nerves, near to the nerve, not into the nerve. This technique is performed using ultrasound guidance, always. When the needle reaches the damaged tissue, the physiotherapist applies a galvanic current with a specific protocol. The current causes a localized acute inflammatory process, removes the waste products, and stimulates the production of the new tissue. This is a video where we have a patient, virtual patient with a patella tendinopathy, and then we check with the ultrasound, we find where is the damaged tissue, and with the ultrasound guidance, with the needle, we reach the damaged tissue. And then we apply the galvanic current with a specific protocol. For every tissue, we have specific intensity. And then also we can treat the interface between the offa fat and patella tendon, where we can find often the neurovascularization of the fibrotic tissue. Scientific evidence. The scientific evidence for the percutaneous electrolysis is not so strong. It's relatively new. It's born in Spain 15 years ago. Sure, we can find almost 70 studies on case report. The most of the case on clinical trial with a small sample seat. Clear in the future is necessary to have more studies, controlled study, multi-century study to confirm the clinical results. The effect of the electrolysis, we have more effect of the electrolysis, but the important is the immune effect. With the electrolysis, we can stimulate one very important inflammasome. The name is NLRP3. This inflammasome causes the liberation of the macrophagus type 1. This is important for the waste, for the elimination of the waste products. And the macrophagus type 2 is very important to building the new tissue. This is a study, is published in Alive in 2022. For the standard intensity for activation of this inflammasome is an intensity between 1,5 and 6. We have also other effect. We have mechano effect, chemical effect, and I don't remember the other. Very important. The electrolyzer don't go alone. Always is very important to reinforcement. After 24 hours, we start to load the tissue. With the power, with the load, we stimulate the formation of the new fiber along the line of force. This is very important. In Spain, we have 3 methodologies. We have the EPTE with low intensity, the HEPI with cumulative charge. Both the therapy is connected with a device. And APM is a methodology from MV Clinic. It's just the methodology. It's not connected with a device. In Switzerland, with the Swiss Association, we use the APM methodology. And then I go to explain about the APM methodology, because it's very important to have one standard methodology. Every physio is important, they work with the same methodology. In the clinical reasoning, we have the APT model. For every tendon, every bursa, we have an anatomic area. For every anatomic area, we have an ultrasound pattern, specific ultrasound pattern. And for every area with a specific ultrasound pattern, we have a specific puncture technique. And then we treat a lot patients with the epicondylitis lateralis. This is an example. Area 1, it is most frequently, is the insertion of extensor carpis radialis brevis. Area 2 is the interface between the joint capsula and extensor carpis radialis brevis. And area 3 is most rare, is the extensor insertion of extensor digitalis communis. For every area, we have a specific ultrasound pattern. For area 1, we have the ultrasound pattern P1, thickening tendon, hypocoic area, neovascularization. And for every area, we have a specific ultrasound pattern. And for area 1, with the specific ultrasound pattern, we have the puncture technique. We have T1. And one example here is a cut, the probe in a long axis in relation to the extensor tendon with an approach in plane with the needle from distal to proximal with an angle 45 degrees. For every structure is described the procedure. And then when we reach the damaged tissue, and we reproduce the pain of the patient, not the pain of the needle, because it's not the same. We connect the device, and then we apply the galvanic current. And for the galvanic current, we have the intensity, the time, and the number impact. In the example, the T1, we have 3 milliampere, 3 seconds, and 3 impact. Periodicity, one we do when we apply. Normally, the protocol is 4-5 sessions, and 1 time in the weeks. And normally, we start the first time, after the second after 7 days, the third after 21 days, and the fourth after 5 weeks. This is a video when we can find the hypocoic area. We reach with the needle, the damaged tissue, and we apply the galvanic current. We can see the cloud is the hydrogen. This is a chemical effect. When we go with the needle, we get galvanic current in the NaHCl, we can produce hydrogen. And we can see in the desk of the ultrasound. This is on course. In 6 weeks, we can find before the little hole in the tendon. In 6 weeks, normally, the little hole is full healed. This is a study from 2000. Is with the patient. And normally, in my experience, before I do this situation when it came a patient with epicondylitis, was not easy. Clear? This is an ORM. It can be good help. And then, this is also important to say, the ultrasound often is combined with the other current, the neuromodulation, the percutaneous neuromodulation, when we have the dysfunction, or when we have patient, when we have not a good immune response, diabetes, immune disease, or this metabolic excuse me, disease, we combine with other high voltage or microcurrent for increase the stimulus.
Thank you very much, Emanuele. That was an overview about the technique. In clinical practice, that's where I just listed the situation in which the technique looks quite promising, quite promising technique. As Emanuele said, there is still a lot of work to do to demonstrate that as well on a scientific basis. Take-home messages from our point of view is it is a really interesting technique that has the potential for selected. Oh, sorry, I don't know. The slides are voila. That has the potential to modify. I cited 3 examples before. It's really important, as with ultrasound and any other therapy, it's really operator dependent. There is really the importance that the physio has a solid training, and for that, the ones who are interested, I suggest you to visit the website cited. The therapy has a strong analgesic effect that can be used, but can be also dangerous. It's really interesting because it's protocolized, so it's really easy to reproduce the treatment in different patients. And there are studies for the different areas. There are many studies that are still lacking. It does not replace active therapy, but I think that's quite logic. And what's also quite interesting aspect of this therapy, you really get patient engagement. They really are, the compliance in doing then the active part, in my experience, high-ends, and probably it's also a reason why this technique works so well in some situations. For more information, you can find here some information to the technique that Emanuele showed you, and we thank you and hope for an interesting discussion.